The women who died fastest were the ones who came in healthy. They weren't sick, they were pregnant. They came for vitamin injections at Yambuku Mission Hospital in northern Zaire. The nurse gave each of them a shot and moved to the next. Same needle, different arm. Over and over, 6 days a week for weeks. Nobody told them, nobody knew. The priest who gave the dying nun her last rites caught the disease at her bedside. He was dead within the week. A scientist in Belgium opened a thermos flask containing blood from a woman who was dying of a hemorrhagic fever that would later be called Ebola. He was wearing latex gloves. That was it. He had no idea what was inside. Nobody on Earth did. The outbreak didn't end because doctors found a cure. It ended because the local population got so terrified of the hospital that they stopped going. The man who touched the infected bodies without gloves, who had his bare hands inside the dead, survived. 280 people who trusted the clinic did not. 88%. The highest kill rate ever recorded in an Ebola outbreak. And the thing driving it faster than the virus could travel on its own was the hospital trying to stop it. His name was Mabalo Lella, 44 years old, headmaster of the Yambuku Catholic Mission School in northern Zaire. He organized road trips for his staff through the equatorial forest, picking up supplies from outlying villages. In August 1976, he took one of those trips. 2 weeks, 6 colleagues, dirt roads through the Mobai Bongo zone, roadside markets selling smoked antelope and monkey meat. He came home on August 22nd with what felt like fatigue. 4 days later, he had a fever and walked into Yambuku Mission Hospital. The nurse gave him a chloroquine injection, told him it was probably malaria, and sent him home. The syringe she used had been through other patients that morning. It would go through more that afternoon. Yambuku Mission Hospital ran an outpatient clinic that saw up to 12,000 patients a month. They had 5 glass syringes. At the end of each day, the nuns rinsed them in water and boiled them briefly. That was the sterilization protocol. Hot water. Assumption. 5 syringes. Lella came back on September 1st, fever still raging. They told him to rest. By September 5th, he was hemorrhaging from his mouth, from his rectum, from his eyes. His liver was failing. His blood had stopped clotting. The Belgian nuns who ran the hospital had seen malaria, had seen typhoid, had seen tuberculosis. They had never seen anything close to this. On September 8, 1976, Mabalo Lella died on a ward cot in agony. His wife Mabunzu and the women of the village washed his body that night. Bare hands, local custom. Then they started dying. Sister Beata was the mission's midwife. The day after Lella died, she delivered a stillborn baby from a woman who was hemorrhaging. She walked away with her hands soaked in blood. She fell ill 5 days later. She was dead within 10 days of that delivery. Sister Beata's colleague gave her last rites. He was dead a week after that. Sister Miriam fell sick. Sister Romana fell sick. Sister Edmonda fell sick. Father Sango Lutens fell sick. Of the 17 people working at Yambuku Mission Hospital in September 1976, 13 got infected, 11 died. 11 of 17, and that was before anyone had counted the patients. Now here is the part that turns this from a tragedy into something that should make every person who has ever sat in a clinic waiting room stop breathing for a second. Every morning, pregnant women walk to Yambuku Mission Hospital for their prenatal care. Vitamin injections, chloroquine, routine medicine that healthy women receive to protect their pregnancies. The nurse moved down the queue with a syringe. Mabalo Lella's blood had been in that syringe. Whatever he was carrying had gone into it on August 26th. The next patient got it, then the next. Then the woman in the third trimester who walked 2 kilometers from her village that morning because the nuns had told her these injections would protect her baby. The WHO International Commission that arrived in late October 1976 traced every single case through 550 villages. Their finding was not what anyone in that room expected. Women aged 18 to 25 had the highest death rate of any group in the entire outbreak. They were killed by prenatal care. At least 85 of the 318 known Ebola cases in 1976 traced directly back to injections at that hospital. The clinic was not fighting the outbreak. The clinic was the engine of it. What this virus was doing inside those bodies was something medicine had never classified before. When it entered the bloodstream, it went straight for the cells designed to detect it. Macrophages, monocytes, the sentinels. It didn't fight them, it infected them first and used them as transport, hiding inside the cells that were supposed to sound the alarm, traveling deep into the liver and the lymph nodes and the spleen before the immune system understood anything was wrong. By the time the body realized it was under attack, the response it launched destroyed it from the inside. What scientists would later call a cytokine storm, inflammatory chemicals flooding the bloodstream in concentrations that shredded blood vessel walls. The liver, by then heavily infected, stopped producing the proteins that make blood clot. Organs failed simultaneously. The hemorrhaging that people saw on the outside, the bleeding from the eyes and the gums and the skin, that was not the virus attacking directly. That was what total systemic collapse looks like from the outside. Patients described it as feeling like every joint in their body was being crushed. On September 19th, a doctor named Ngoy Mushola radioed an alert from Bumba Zone to Kinshasa. He had been watching people die for 4 days, and the numbers were not matching any disease in his training. The Ministry of Health dispatched a 34-year-old microbiologist named Jean-Jacques Muyembe-Tamfum. He drove to Yambuku. He put on latex gloves. That was his only protection. He examined the dying patients. He took blood samples with his bare hands inside the vials. He took liver biopsies from the dead. His hands were stained with infected blood multiple times. He washed them in a basin between patients. He survived. 49 years later, he is still working on Ebola. He sent the blood samples from Kinshasa to Belgium on a commercial passenger flight, packed in a blue thermos flask with dry ice and 2 glass vials drawn from Sister Miriam, who by then was dying at a hospital in the capital. One of the vials cracked in transit. The thermos was leaking when it landed in Brussels. It arrived at the Institute of Tropical Medicine in Antwerp on September 29, 1976, and was handed to a 27-year-old virologist named Peter Piot. 2 years out of medical school. His professor had literally told him there was no future in infectious diseases because they had all been solved. Piot opened the thermos wearing latex gloves and nothing else. He inoculated cell cultures, inoculated newborn mice. The mice died. He prepared specimens for the electron microscope. What he saw were filamentous particles, thread-like, coiling, forming shapes like question marks. There was only one filovirus that looked like that, Marburg. Except when the CDC ran the cross immunofluorescence test in Atlanta, it didn't match Marburg. it didn't match anything. On October 13, 1976, a virologist named Frederick Murphy shot an electron microscope image of the pathogen, walked the still dripping print down the hallway, and put it in front of the CDC director. New species, unknown to science. A filovirus burning through northern Zaire with an 88% kill rate. They had to name it. Carl Johnson at the CDC knew what happened when you named a virus after the place it came from. A village in Nigeria had been living with the name Lassa fever since 1969. That stigma was permanent. Johnson and his colleague Joel Bremen looked at a map of northern Zaire and found the nearest river to Yambuku, the Ebola River, about 60 kilometers from the mission compound. They called it Ebola. The map later turned out to be inaccurate. A different river was actually closer, but the name was already in the cables. The village of the Yambuku was spared. The river took the name instead, and the word Ebola, chosen from a wrong map in the deliberate act of mercy, became one of the most feared words in medicine. The WHO International Commission arrived in late October with helicopters because President Mobutu had already sealed the entire Bumba zone. 275,000 people. No commercial flights in or out. Army at the perimeter. The Commission surveyed 550 villages, traced every case. Their recommendation came back on October 3rd. Close the hospital immediately. The outbreak peaked and collapsed within 3 weeks of the closure. Not because of a drug, not because of a vaccine, because the local population had become so terrified of the hospital that they stopped going. And when the needle amplification chain broke, the virus ran out of road. The last case died November 5, 1976. 318 infected, 280 dead. 88%. History books mention once and move past. In June 1976, 3 months before Lella walked into that clinic, a cotton factory worker in Nzara, southern Sudan, developed a hemorrhagic fever and died. The outbreak that followed killed 151 people in a location 850 kilometers from Yambuku. When CDC scientists ran the cross tests, the pathogen was not the same virus. Different filovirus entirely, what would be classified as Sudan Ebola virus. 2 separate Ebola viruses, 2 separate outbreaks, same year, no link between them. It has never been explained. And the source of what Mabalo Lella was carrying when he walked into that hospital on August 26th has never been identified either. Replicating Ebola virus has never been isolated from a wild animal, though fruit bats of the species Rusetus aegyptiacus remain the leading reservoir candidate. The reservoir that passed it to him, somewhere on those August forest roads, is still unknown. The first known Ebola outbreak, at its origin, remains an open question. Jean-Jacques Muyembe-Tamfum went back to Kinshasa and spent the next 5 decades on Ebola. Every DRC outbreak. The 1995 Kikwit epidemic, where he pioneered transfusing blood from survivors directly into dying patients. 7 of 8 lived. He co-developed a monoclonal antibody therapy, MAB-114, later named Ansuvimab, from a Kikwit survivor's immune cells, validated through the PALM clinical trial, Pamoja Tulinde Maisha, and approved by the FDA in 2020 as the first licensed Ebola treatment. He ran the field vaccine trials using RVSV-ZEBOV during the 2018 to 2020. Kivu outbreak, 3,470 cases, while he was in his late 70s. Peter Piot, the 27-year-old who opened that thermos in latex gloves, went on to co-discover HIV. He ran UNAIDS for 13 years. He nearly died of COVID-19 in 2020 and recovered. Mbunzu, Mabalo Lella's wife, survived. She hemorrhaged. She recovered. In 2018, researchers drew her blood as part of a study of the original 1976 survivor cohort. Her neutralizing antibodies were still there, 42 years later. Her immune system still remembered the exact shape of the thing that tried to kill her. The 5 glass syringes that ran through Yambuku Mission Hospital without sterilization built something the nuns never intended. Every single-use syringe mandate in sub-Saharan Africa. Every PPE protocol in outbreak response. 51 BSL-4 Biosafety Level 4 maximum containment laboratories now operating in 27 countries. All of it traces some part of its existence to what those 5 syringes did to a prenatal queue in northern Zaire. Mabalo Lella got a malaria shot for a fever that probably wasn't malaria. He was home within the hour. He was dead in 13 days. And the infrastructure that now protects the world from the next unknown pathogen was built, piece by piece, on what his death taught medicine about what happens when you hand a virus a needle. There is another story from the same year, same mechanism, different pathogen, different continent. A medical system amplifying something it didn't understand faster than nature ever could have managed alone. That story is next.